Then I'll start. I'm very grateful to be a part of this satellite symposium. And I'm here to talk to you about FLT3 inhibitors and current approaches to the management of relapsed and refractory FLT3 mutant AML. Here is a disclaimer. And I think most people listening to this seminar are aware that a FLT3 mutation in AML is a bad thing. It was a bad thing when we used non-intensive chemotherapy, and the data on the left are from 20 years ago. And they are continuing to be bad things even now in the era of venetoclax-based therapy, where we know that patients with FLT3 mutations tend to get a remission less often and relapse quicker afterwards. Now, in the relapsed setting, things truly are worse. Here on the left are data from the MD Anderson Cancer Center, where they looked at outcomes of relapsed AML, where of course it's bad, but if you relapsed with a FLT3 ITD mutation, pretty much everybody died when using conventional chemotherapy. And the data on the right are from cooperative groups out of Europe, which essentially concluded that a FLT3 mutation was essentially the worst prognostic feature of relapse. So we know they're bad at both diagnosis and relapse. Now, we have two FLT3 inhibitors in the world most widely used. Yes, of course, there are many that I'm not going to touch on. The reason I'm focusing on these is that they have current regulatory approval for the treatment of AML over a broad section of the world. That's midostaurin and gilteritinib. And what I'm showing here are diagrams with the chemical structure of each, the kinome, which is a reflection of their selectivity to some degree, and more on that later. And then the Western blots, the immunoblots shown below, are reflective of the inhibition achieved in vivo in patients actually taking the drug. And gilteritinib, compared with midostaurin, tends to inhibit the target much more effectively. Now let's first focus on midostaurin. It has the advantages of being effective against both ITD and TKD types of FLT3 mutations, and when given in combination with induction chemotherapy, intensive chemotherapy, it does prolong survival for newly diagnosed FLT3 mutant AML, but it has almost no activity as a single agent, and that's because it doesn't inhibit FLT3 really very well in vivo. Furthermore, patients routinely stop this medication due to gastrointestinal toxicity. In other words, they can take it for a couple of weeks. They can't take it for a year very successfully. Most studies show them stopping it before long. Now, going on to gilteritinib, again, it inhibits both the ITD and TKD mutations, and it prolongs survival in comparison to salvage chemotherapy in the relapsed setting for FLT3 mutant AML. We'll go over that data. This drug is very easy for patients to take. It has virtually no side effects. 3 tiny little yellow pills, and you can titrate the dose very easily. According to the situation, patients could take 1, 2, or 3. 3 is the approved dose, but sometimes you have to dose reduce for reasons I'll discuss. Very easy to do. Disadvantages, it is a bit myelosuppressive, except in certain circumstances, usually after an allogeneic transplant or in the setting of intensive chemotherapy. But by itself, in the relapsed refractory setting, no, it's not very myelosuppressive. It does have a very long half-life. So if you think it's causing some issue and you want to stop the drug, it will take a while for the effects to wear off. Now, it is highly selective for all of the FLT3 activating mutations at clinically relevant concentrations. So shown here is the more accurate kinome diagram, and this drug is really more selective and potent against the activating mutations compared to the wild-type receptor. So really, the receptors it hits best amongst the whole human genome are the FLT3 activated receptors. So let's talk about the Admiral trial, and I put up a butterfly here because, in fact, Astellas likes to name its gilteritinib trials, its Zospata trials, after different versions of butterflies. And this one is the Admiral butterfly. So the Admiral trial was a randomized trial, open label, 2-to-1, salvage chemotherapy, and you had to get either pre-chosen for either high or low intensity, versus single agent gilteritinib for relapsed or refractory FLT3 mutated AML. And patients who were on the gilteritinib arm, who then were bridged to a transplant, could resume the gilteritinib after the transplant. So a 2-to-1 randomization, and we see the breakdown of the patients. Very typical FLT3 mutant relapsed refractory population, if you will. The age was 62. Most of these were intermediate karyotype, and most of these were ITD only. There were, however, some TKD only mutations, which were important to characterize. And the results, I think, are well known. These are data from a few years ago showing that gilteritinib easily was superior to salvage chemotherapy with a hazard ratio of 0.64 and a 12-month overall survival of 37% versus 17%. Now, the co-primary endpoints of this study was response, and we looked at both what's called CR/CRh. CRh refers to a hematologic improvement. It often is associated with transfusion independence, but it really is a clean remission, not necessarily a CRi or CRp. A CRh really was very meaningful to regulatory agencies, and it was a 34% in the gilteritinib arm, really quite high compared to the 15% in the salvage chemotherapy arm. But in fact, the agent is really even more active than that. When you summarize all of the ways of responding, clearance of peripheral blasts, partial reductions in the marrow, or a CR with incomplete count recovery, it was really 2/3 of patients had some sort of response on single agent gilteritinib. Breaking it down by different subgroups, virtually every group you could look at, karyotype or whether or not they were refractory or relapsed, patients randomized to high or low intensity chemotherapy, they all did better with gilteritinib. The one group that perhaps didn't were patients with an unfavorable karyotype. And there, I think, those are uncommon. And I think really what you're dealing with is a subclone of cells that express a FLT3 receptor. Most of the disease is not driven by FLT3. I think that's probably real, that that entity is probably the one tiny group of patients that may not benefit much from gilteritinib, but I would still consider trying it. Because the drug is far better tolerated than salvage chemotherapy, as shown here in the exposure-adjusted adverse events, grade 3. So remember, yes, there were more adverse events in patients on the gilteritinib arm, but that's because they were on that drug for months because of the response rates and the duration of response. So in fact, if you adjust it for the amount of time they're on it, the salvage chemotherapy event rates, adverse events were far higher. Most of what you get with gilteritinib are increases in the ALT, the transaminases. That's the most common thing. Patients aren't even aware of it. There really wasn't much of a QT signal. And this is now, we looked more closely at the long-term follow-up of these patients. So here in this consort diagram, we actually noted that there were patients who were clearly long-term survivors, and we wanted to look more closely at these patients. So there were 26 long-term survivors in this trial on the gilteritinib arm. And you'll note over in the far left, most of those patients were bridged to an allogeneic transplant. In other words, they were relapsed refractory, they got gilteritinib, and were transplanted. Yes, not surprising. Interestingly, though, there were some patients who were not bridged to a transplant, but it turns out most of them had relapsed after an allogeneic transplant already. And we think they were probably experiencing some degree of an allogeneic effect, which was synergizing with the FLT3 inhibition. For long-term follow-up, when we looked at a reanalysis a couple of years later, the survival benefit held up. And in fact, more importantly, you can see a plateau where we see these long-term survivors out there. And so this is really extraordinary. We've got some patients that, for all intents and purposes, are cured. And I do have them in my clinic. I know they exist. These patients can be cured in some instances, again, usually associated with an allogeneic transplant. So these patients, these 26 patients living without relapse for greater than 2 years, again, most of them underwent either transplant on the trial or had relapsed after an allogeneic transplant. And it didn't matter whether they had a high or low allelic ratio, and in fact, some of them had even stopped their gilteritinib. So, looking at the characteristics for these patients, again, shown over in the lower right here, most of them had had an allogeneic transplant, even the ones who were not bridged. So this is in fact focusing on those 8 patients who were not bridged to a transplant. 7 out of 8 of them had actually relapsed after a transplant. Again, no obvious signals as to why they would be unique and such long-term responders. We did have the opportunity to look at adverse events of interest during this course of long-term treatment. And what you can see is, again, as I emphasized, increased ALT, increased AST are the most common adverse events, if you want to call them that. Patients come into my clinic all the time with this. They say, I'm fine, I have no side effects. And I say, oh, look at that, your transaminases are a little bit elevated. What I will tell you is I often do nothing about that. If they're very slight, if it's a grade 1 elevation, I usually just follow that, because I'm likely going to take the patient off gilteritinib eventually, and it usually goes away. You can get very occasional other side effects, but I think the patients almost never notice what's going on. They feel perfectly well on this drug. Now, again, focusing on allogeneic transplant, patients on the Admiral trial, if they had salvage chemotherapy and managed somehow to get into a remission and go to transplant, we looked at the outcome of such patients compared to the gilteritinib patients who went to transplant, and there was pretty much no difference. And the reason we wanted to do this was we wanted to demonstrate that a gilteritinib remission could be transplanted as effectively as any other type of remission. They were real remissions. So overall, of the patients who underwent allotransplant on that Admiral trial, some of them actually went back on gilteritinib maintenance therapy after the transplant. A few of them had to have dose increases due to adverse events. And in my experience, this usually is mild count suppression. And I usually just drop the dose at that point to 80 milligrams or sometimes even 40 milligrams. The relapse rates in patients who went back on the drug was quite good. Here, this is a comparison from that trial. Now, understand, this is not randomized. You can always make the argument that a patient who went on gilteritinib after their transplant was somehow more fit than the ones who did not resume gilteritinib, and that's why they did better. Fair enough. We actually are assessing this question in a randomized trial after transplant, but this was at least reassuring that we recommend patients go back on gilteritinib if they're bridged to a transplant on gilteritinib. Now, importantly, this same trial, this Admiral trial, was kind of reproduced in the Commodore trial. Again, here we see the butterfly. That's a Commodore butterfly. Again, this was open label, phase 3, took place over much of Asia, and very similar results, as you can see. A higher CR rate in the gilteritinib arm, and here's the survival curve from that. So again, we have 2 randomized trials demonstrating the obvious benefit of this drug over salvage chemotherapy for relapsed refractory FLT3 mutant AML. So now I want to end with some practical advice in using this drug. I have been using this drug in clinic for years here in the US, and I think I have learned a few things which I can share with you. So first of all, in the NCCN guidelines right now, gilteritinib is a category 1 recommendation for relapsed refractory disease with a FLT3 mutation, either TKD or ITD. It is important to understand the pharmacokinetics of this drug. Very long half-life. It is CYP3A4 metabolized, And giving a concomitant azole, which we often do, will double the concentration of the drug. It also you should know that there's no food effect. You can tell the patient they don't have to take it on an empty stomach or whatever. But you need to be aware of the increase in the concentration with an azole. Now, would you say, is this a bad thing? Do we have to worry about that? I would say no. I don't worry much about using an azole with this drug. Why? Well, when we developed this drug and this dose, we actually we did it by in vivo FLT3 inhibition. We found that we actually could increase the dose all the way up to 300 milligrams in patients, and they tolerated it. That was more than we needed. 120 milligrams gave us adequate inhibition in vivo, but you could safely go up 2 or 3-fold higher. So I'm not particularly worried about giving somebody, particularly in the monotherapy setting, an azole. Yes, they'll get a slightly higher concentration of the drug, but it appears to be very well tolerated. Now, I'll finish with a case presentation. This is a 79-year-old man who came to us, I want to say, a few years ago. He was retired, he golfs, likes to drink martinis. Past medical history, he had prostate cancer and radiation 2 years prior to his diagnosis, a little hypertension. So it was October 2020, a couple years ago. 1 month of progressive fatigue. His bone marrow, he had a white blood cell count of 27,000, circulating blasts, kind of bad counts. I'm sorry, there's an error there. It's not a day 14 marrow. This was his bone marrow biopsy. Hypercellular, it was AML. Okay, so we sent molecular studies, and here are his genetic results. We see the FLT3 ITD mutation, 33 base pairs with a VAF of 34%. There is an SRSF2 mutation. This is consistent with his having myelodysplastic syndrome, I think, beforehand. If this disease can rise out of an MDS. ASXL1, RUNX1, and he had a trisomy 13, which, by the way, is the chromosome FLT3 is on. So PCR shows the FLT3 ITD mutation in the NGS panel. Now, classifying that, okay, that is called intermediate risk, I guess, or perhaps adverse. The variant allele frequency is borderline high, and there's not an NPM1 mutation, so he's probably adverse risk. Now, this classification scheme has since been modified, and they've lumped all of these patients into intermediate risk. We would call this bad in the 79-year-old patient, so I think it's kind of irrelevant what the ELN calls it. So getting back to our patient, we've got this newly diagnosed AML, technically a treatment-related myeloid neoplasm because he was treated with prostate cancer. ELN unfavorable, whatever you want to call it, with a FLT3 ITD mutation, and he's not fit for intensive induction. So in the US, the intensive options are 7 and 3 and midostaurin, or we could give him CPX-351, which is liposomal daunorubicin and cytarabine. However, other options for him, supportive care, decitabine or azacitidine, or he could get a hypomethylating agent with venetoclax. And we decided to do, with his choosing, azacitidine plus venetoclax. So we admitted him for 7 days, gave him outpatient supportive care during the aplasia, and he completed 2 cycles. He remained transfusion dependent the whole time. And here was his CBC at the end of 2 months, still low white count, no neutrophils, transfusion dependent with a low platelet count. We did a bone marrow biopsy. The blasts are still sitting there. And we resent, very important, we resent his molecular studies essentially unchanged. So this was utterly unresponsive to azacitidine and venetoclax. So the FLT3 ITD mutation was still present, and we started him on Zospata on gilteritinib 120 milligrams per day. And at the start, the marrow was 50% cellular, 30% blasts. And these were the concomitant medications. We kept him on. Look, he's on levofloxacin, posaconazole, Valtrex, and he was bleeding, so we had to give him aminocaproic acid. At 4 weeks, the bone marrow was now 20% cellular, and blasts were down to 5%. And at 8 weeks of therapy, 10 to 20% cellular marrow, and now down to 3% blasts. And this is an important point. You should be patient with this drug. Give it 1, 2, 3 months. And the patient can, we're not worried about his concomitant medications. Remember, azoles do double it. No food effects. We said, eat whatever you want. We don't care. Go about living your life as best you can. He initially was getting platelet and red cell transfusions twice weekly. And shown here are his blood counts over that time. So you'll see his platelets at around week 8 start to rise. And no, they didn't get normal. They were around 40 to 50. But he no longer needed platelet transfusions. He no longer needed the Amicar, and he stopped having any bleeding problems. You'll see his hemoglobin rose up to almost 10 and kind of stayed that way for a few months. And you'll show here we see his absolute neutrophil count rising rapidly and going up, not quite above 1,000, but it was up there. So he became transfusion independent by 10 weeks of therapy, and he went back golfing. It's important to recognize that gilteritinib is not associated with marrow suppression or increased transfusion needs. Of patients who were on the Admiral trial who were assigned to gilteritinib who were getting transfusions, a third of them actually became transfusion independent. And those who were already not requiring transfusions tended to maintain that independence. So this drug really can preserve that and even restore transfusion independence. Again, focusing on quality of life. Now, yes, there is an obvious relapse rate over time. The duration of remission is good, but it is not to the end of time. And so after a year or so, patients are going to progress on this monotherapy. How do they progress? Well, they develop RAS pathway mutations, mostly just straight out in RAS, but PTPN11 also. Occasionally, there's a gatekeeper mutation emerging in F691L in FLT3. So we looked at him, and sure enough, he had developed a KRAS mutation at 24 weeks. And his blasts were beginning to progress, and there was the sign of resistance. He was still actually doing fairly well, but he continued on therapy. Finally, after 34 weeks, he did decide to withdraw. He developed a severe pneumonia, and he did die. But the reason I think he's in an important case, we have a 79-year-old refractory leukemia with no options. We gave this man 3 little pills and sent him back golfing. And he did, and we never told him he was going to be cured, but he had 6 to 8 months of very good quality of life on this medication. And so gilteritinib for patients with relapsed or refractory FLT3 mutant AML, overall response rate greater than 50%, very well tolerated, minimal drug interactions, clearly improves survival compared with chemotherapy, and provides quality of life in addition to longer life. And I'll stop there, and I'm happy to take any questions.